Now, without further delay, let's begin today's event sponsored by Maestro Health and hosted by Employee Benefit News and Employee Benefit Advisor. I'd like to introduce your moderator for today, and that is Lynn Gresham, freelance writer and former editor-in-chief for Employee Benefit News. Lynn, you have the floor.
Thank you, Adam. Good day, everyone. We're pleased to have you with us for this web seminar. It's not you, it's healthcare. What's next for access and employee education? When people are sick, the last thing they want to do is shop for a doctor or research their next steps. Happily, there are emerging and proven virtual tools and educational resources that can simplify access to quality care and help lower costs, as you're going to learn today from our two speakers. They are Daniel Trencher, Senior Vice President of Product and Strategy at Teladoc Health, and Steve Kaltreiter, Senior Product Director at Maestro Health. Gentlemen, welcome to you both. Steve, I'll now turn the program over to you.
Thank you, Lynn. Let me first set the stage for what we're going to talk about today. First, as an independent TPA, we'll show you the most popular access and care models we're seeing. Next, we'll discuss several emerging virtual care solutions. Then we'll introduce you to the concept of personalized provider access. And last, we'll wrap it up with some best practices and ideas in educating members. And we're going to do this through the lens of three trends that we're seeing. When people become patients, they don't shop like retail consumers. This is their health. It's not a big screen TV decision. You've been there, you're sick, you've got a new diagnosis, or you've just been told you need a medical procedure. You're scared, you're vulnerable, and it's the year 2020. You just want answers and fast. Number two, we hear it all the time from employers and brokers. The savings from large carrier PPO networks are not enough. They want more provider access options at lower costs. And number three, we've all heard about the shortage of primary care physicians. The Association of American Medical Colleges estimates a shortfall of 21 to 55,000 primary care docs by the year 2032. And now, a study published just last month shows us this disturbing trend. Over an 8-year period, the U.S. has seen a 24% decrease in primary care utilization, and over that same period, there was a 47% increase in urgent care utilization. So now, on top of the worsening shortage of primary care docs, people are choosing a more expensive option. Dan, are you seeing this impact virtual care?
Yes, Steve. First, it's worth digging a little deeper into the numbers, as you'll see a big demographic component. Almost half of millennials don't have a PCP, and almost a quarter of people overall don't have a PCP in the United States. And we're talking at that point about 65 million people without a primary care physician relationship. The reasons are many, but a desire across the board, really, for greater convenience and the ability to access care on your own terms is driving patients to skip having a PCP. More consumers are accessing acute care when they need it from an urgent care center or a retail clinic, but certainly we're seeing an even more dramatic growth in the use of virtual care.
So let's talk about the high-level access and care options that we're seeing. In 2019, 65% of our new employer clients chose the model that you see here on the left. This is the one we're all most familiar with. It's been around for decades. A large full-service PPO network that includes, virtually all provider types. It's typically a rented network from one of the large carriers, like Cigna or Aetna. Looking at our own historical data across multiple geographies, on average, about 90% of claims dollars are typically in-network in this model. On the far right is the complete opposite, a model where there's no network at all. In its place is a reference-based pricing plan. For those unfamiliar with RVP, under this model, members go to any provider willing to see them. The providers submit claims to the TPA. The TPA coordinates paying the providers, typically a multiple above what Medicare would pay. It can result in substantial savings over the traditional model on the left. But members may have difficulty getting providers to see them. They may be required to pay up front, or they may be balance billed for the difference between what the provider was paid and what was billed. Employers love the savings, but many don't like the access and balance billing noise that comes with it. This model was popular for years for us, but in 2019, we actually saw no new sold cases under this model. Instead, 35% of our new clients opted for the model in the middle, where about half the claims are in-network. In this model, we're putting a physician-only or physician plus ancillary network in place. And as I said, about half of the claims fall in-network, but those claims account for only 22% of the claims dollars. The reason for this is physician ancillary claims are not high cost. The facility claims are. And in this model, the facility claims are all being reimbursed using reference-based pricing. But 78% of claims dollars reimbursed using RVP is still too much noise for some employers. They want the RVP-like savings, but without the noise. So TPAs, brokers, and employers are curating a host of vendors who are stepping into this space for a share of that 78% of claims dollars. We call it personalized provider access. Some of the common categories are imaging, labs, virtual care, and bundled surgeries. Each of these categories has a webinar worth of material, but we're going to focus on just two: virtual care and bundled surgeries. Elaine and George are suddenly patients in the healthcare system. Elaine has excessive eye watering, redness, and blurred vision. After battling angry seas to save a whale, George has weakness, pain, and tingling in his back and left leg. Let's assume Elaine's employer, Jay Peterman, and George's employer, the New York Yankees, are operating under that middle model we just talked about, a physician-only network where 78% of the claims dollars are not covered by the network. Through her employer, Elaine has all of these options available to her. She doesn't see the number on the left, which represents the typical allowed amount, but the number on the right is Elaine's copay. As you can see, whether she's reached her deductible or not, the telemedicine virtual option is the most cost-efficient for her. Dan, can you talk about how Elaine's situation would be handled in the virtual care world and some of the emerging trends that you're seeing?
Absolutely, and I hope everyone is enjoying our Seinfeld our examples here. Elaine's situation is actually a pretty common use for telemedicine, and where it first caught on back more than 15 years ago for handling common, quote-unquote, urgent care type conditions, such as pink eye and sinus infections and rashes. What's interesting here is that Elaine's employer is offering virtual visits with no cost sharing to her. You'll see that there, $0 copay. This is a plan design that we always recommend as part of a virtual first strategy, right? So as the small investment by the employer in covering the full cost of the visit can have a huge impact on members trying and utilizing virtual care, which ultimately delivers a higher overall ROI for the employer. But George's clinical situation is a bit more complex, perhaps, so it lends itself to a more in-depth specialist review. So let's talk about that. George is a great example, honestly, of a member who is faced with some uncertainty about a pretty serious medical question and needs some help. Some members, like George, know their questions and just need the right person to ask. And some don't know what they're looking for exactly and need more help. Some common questions that we come across in offering expert medical services are, is this the best treatment for me? I've had a diagnosis and a recommended treatment. I'm not sure if it's right for me. That would sort of tie into George's example. Sometimes it's an ongoing condition, and somebody's been diagnosed and treated over time, but they're just not getting better, and they'd like a second review. And sometimes it's just finding a high-quality and network provider in their community. Whatever the member concern, whether it just happened today or it's been a problem that's been lingering for what seems like too long, expert medical services or expert medical opinion can offer resolution. So we're here so your members like George have someone to turn to, someone who makes facing issues easier and someone who can deliver the benefits of resolution. And on the right side of the slide there are some examples of what resolution looks like. More education about treatment options. Second opinions from a provider who specializes in the care that they need, and access to more affordable treatment options. These are all very common examples of how we see members getting value from expert medical reviews. So here, let's dig a little deeper into George. So George does not have a primary care physician, like many people that we talked about earlier. He looks and he's told he can't get an appointment with a new PCP for 54 days. And this is not a hypothetical. This is actually very common, and the stat ties to a Merritt Hawkins survey on physician appointment wait time. So this is very representative, unfortunately. But he is, not surprisingly, able to get in to see a back specialist within about 2 weeks. He's told he needs multi-level removal of discs and spinal fusion, which will ultimately reduce George's spinal mobility. This is obviously a very serious surgery with a very serious implication for George's health. He's not sure, and so he recalls that his employer has a virtual second opinion benefit, so he decides to give that a try. So this walks through the process a little bit, and where I most want to make sure we start is with the crux is that the expert medical opinion centers around the physician-member relationship. So it starts by George virtually connecting with the physician who takes the time to understand his unique needs and works with him ultimately to find a resolution for those needs. It's through these conversations between the member and their physician that the member's personal and health needs are really understood and the appropriate path of care for that individual in a personalized way is determined. So George would start by having an intake conversation with the physician. They would talk, physician would really understand the situation, the history, what George's concerns are as you think about this sort of surgery. If necessary, they will bring in an expert specialist, so in this case, an expert specialist on back orthopedics. Sometimes the physician can handle the case on their own. What's important is as we do have an expert medical review, we gather all the patient's medical records, including imaging. If it were a case that involved pathology, we'd retest pathology. And this all enables a very thorough and unbiased review of George's diagnosis and treatment plan. And just to say it, we're not saying that George's first provider, their local provider, isn't good, but we are removing the barriers to good care. So stats, for instance, stats say that it takes new medical evidence-based practices up to 17 years to trickle down all the way through community healthcare practice and become the standard of care. And the average doctor visit is 7 minutes, and that's just not enough time to really necessarily get to the right answer for each patient. our physicians, through our process, at the time to really learn about the member, their history, their concern, their family life, to provide a personalized, holistic view of the member to get the right path to resolution. And just to say it, our doctors have no financial interest either way in the outcome of the case, which brings out the most unbiased recommendations for care. So in George's case, the specialist delivers on a revised diagnosis and treatment plan. So the recommendation is still for surgery, but for a different surgery, in this case a microdiscectomy, which is minimally invasive and has faster recovery times. So George feels really good about this path and decides that's how he wants to go forward. Of course, the next step is to decide where he wants to get that surgery, but we'll come back to that question in a minute. So this slide really highlights, or in George's case really highlights, a great example of the use of expert medical services. So I wanted to stop for a second and really look at some of the stats around impact. So 1 in 4 cases, when we do rerun pathology, for instance, finds an error in or misdiagnosis based on that pathology. When we look at musculoskeletal surgeries, we see 38% of those are avoided, and that's obviously dollars and cents, avoiding that many unnecessary surgeries. Critically, in many cases, it is not a 180-degree reversal of a patient's existing diagnosis or treatment plan, but there is an improvement, right? And even small improvements in treatment can have a huge impact on outcomes and ultimately cost and quality of life. And so that shows up in improved 79% of cases with improved treatment and 45% with improved diagnosis. You add it all up, and members are really satisfied with the service, and so 90% plus are satisfied. And perhaps most rewarding, 95% of members move forward with the recommendations that are provided to them, which really shows the value and the quality of the services, but also how they're able to follow through and get to the best outcomes for their particular case. So let's take a step back. So we've been talking about George and Elaine, some specific cases, and maybe take the longer view on virtual care. As we look to the future, virtual care really is increasingly becoming an essential and central strategy for our clients in expanding access, improving outcome, and controlling costs. Whether that's for a health plan who's really utilizing virtual care to achieve new levels of engagement with their patients, whether it's with a hospital system that is really being able to manage their patient populations differently via virtual care, and obviously in our environment today and what's happening all around us with COVID, we're seeing that every day, and new and really important uses of telehealth in the delivery of care for patients. And our examples of George and Elaine also showed the range of virtual care today. So virtual care is optimized to serve really as an entry point, a front door, if you will, to better healthcare experience. So virtual care uniquely streamlines the experience and guides people to the right care right away. This is across a wide range of clinical conditions and member needs. To really realize the full impact of virtual care, organizations, they really do need to include it as a core component of their strategy. Today, we really are partnering with clients in many cases to deliver this virtual-first healthcare experience where their members or their patients utilize virtual as the first point of entry into the healthcare system. And sometimes then they receive immediate resolution, diagnosis, and treatment. Sometimes it's access to expert medical advice, more information about treatment options, mental health care, and sometimes it's just a referral into a high-quality and network community provider. So all of those different sort of value props all tied to accessing virtual as an entry point into the healthcare system.
Okay, so let's review George's situation again here. So George was first told he needed a multi-disc removal and a spinal fusion, highly invasive kind of procedure. His second opinion, though, recommended a microdiscectomy. So now that he has this second opinion, how does he know where to go to receive this procedure? Well, that depends on what his employer has put in place to address the 78% of claims dollars not covered by the physician network. Remember, we're talking about that middle plan that we showed on the previous slide. Over the past few years, TPAs have implemented several solutions to address this. All have the pros and cons and require carefully worded plan language and incentives to administer. So let's walk through some of them. Several vendors have put together bundled procedure networks that include fees from all providers and facilities. For surgeries, the bundled price typically combines the surgeon, the anesthesiologist, and the facility's fees rather than all those coming separately. There's several models. Even under this model, there's several micro models, if you will. Some will have just a couple of dozen sites across the country, and they come with more of a medical tourism approach. And then there's others who will have hundreds or even thousands of contracted facilities. Next, there's a model where single case agreements are put in place and paid on the date of service. Under the traditional claims model, it may surprise you to learn that on average, it takes a little over 30 days just for us to receive a claim from the provider. It's tough to run a business where it takes 30, 60, or 90 days to get paid. So the paid at time of service nature of this solution trades quick cash flow for substantial discounts. You've likely seen announcements from Walmart and other jumbo employers about their Centers of Excellence programs. Well, now the emergence of Center of Excellence networks is making this available for small and mid-sized employers as well. Under these models, the different providers, there's different providers for each surgery type that fall under these networks. So, for example, in the Walmart model, Geisinger is on their list for bariatric, cardiac, and spine surgeries, but they're not on the list for joint cancer and transplants. The Fair Market Medical Association consists of providers who post their actual prices online. They're gaining momentum in the direct-to-consumer space, but several employers and a handful of TPAs are setting up agreements to make it simpler for their members to take advantage of them also. For example, our TPA recently signed an agreement with the Surgery Center of Oklahoma. And of course, some employers are putting direct contracts in place with local providers. Again, this has traditionally been available only to the large employers, but small to mid-sized employers working to aggregate lives through brokers or TPAs are beginning to take advantage of this option as well. But having great benefits and provider access options doesn't help employees unless they know about them and how to access them at the time of need. It's critical to know how your employees want to have their benefits communicated to them. Recent surveys show email to be the safest default bet. HealthSpark found that 57% of respondents rank email the highest. 28% preferred direct mail. I know I came from the Medicare world where it was the opposite of that. Medicare world, seniors read their snail mail. So it's an interesting stat that to see this, but to see that still direct mail in the commercial space is still a popular way to have everything communicated to them. But there's no cookie cutter approach. Employer culture and demographics play a big role. Some of the vendors we work with are quite sophisticated in their member education and marketing efforts. Others rely on the employer or oftentimes the TPA to handle that. It's important to find a TPA partner who can leverage the more advanced vendors' marketing approaches while filling in the gaps for those who are less sophisticated. Dan, can you describe best practices you've seen in the virtual care arena around communicating these benefits?
Sure, Steve. Here at Teladoc Health, we've refined a specific approach to doing this work. We call it surround sound marketing, and that's what's shown here. It's a systematic way of understanding how to reach members where they are and delivering the right communications at the right time. It's often informed by analytics, right, which allows us to target the messaging, target the modality or media, and then hit them at the right point in time. Interestingly, the average number of touches it takes to break through in a sort of a traditional setting has been about 7 to 10. If you talk to marketers, that's what they say. In our experience in virtual care, it's actually more than that. It's 12 to 15. And you can imagine part of that is because it is still a relatively new category for many consumers. If you're actually looking at behavioral health specifically, it can be as high as 18 to 20 touches from a marketing perspective. Again, in that case, you're actually trying to motivate somebody who may not feel like they need access to behavioral health services to try it out. At Teladoc Health, we deploy more than 40 million communication touch points each year, sequenced and tuned to different populations, different clinical services, different times of the year. So this slide lays out horizontally what I think of as the funnel for driving engagement and utilization of virtual care. It starts by ensuring that members, your employees, know that they're eligible for virtual care services and are aware of how to use it and when to use it and perhaps get registered even before they need it. And there are specific types of communication methods that work very well for that goal, and such as in the inbox and even the snail mail. Second is driving top of mind moment of need awareness. So think of this as when you're sick, you remember that you have access to virtual care and then utilize it at that moment of need. Third, this is probably the least obvious, is that members need to have confidence that they're going to get a high-quality, clinically high-quality experience and get resolution to their needs. And here, richer media are often really effective. So videos and of course, word of mouth, right? So you trust the people that you work with or family members. And so it really takes each of these steps in the funnel to help drive that engagement and utilization and ultimately better results for employers.
Well, that wraps up our webinar for today. We discussed the prominent access and care options we're seeing. We took a deep dive into virtual care and the need for personalized provider access. And we wrapped it up by describing best practices in communicating with members. I'd say there's 3 key takeaways here. 1, you've got to get the plan language right. 2, you need to put incentives in place so the benefits are realized. And employers, don't be afraid of zero and low cost share to reap the large savings. And 3, make sure your employees know about the benefits when they need them. We hope you found this helpful and that we've given you some things to think about. Lynn, do you want to open up the Q&A?
Yes, I do, Steve. Thanks very much. Obviously, from the questions, we have given them a lot to think about. The first question is, can you talk more about the financial incentives for the physicians or lack thereof that facilitates independence of care? And how does this compare to traditional primary care?
That
sure.
Sounds like it's
Dan.
Probably a question for Dan. Yeah, go ahead,
Yep,
Dan.
happy to take that. So I'll frame it around what I talked about during the presentation. where maybe these are physicians who are helping with an expert medical service. So it certainly could be true of any virtual care service. What's important is they are compensated for their time, right? However that's structured, and so there are no particular incentives for them to recommend against a surgery or recommend for a surgery. But it's really for their time and also the quality of the care that they deliver, which we measure via sort of our quality programs retrospectively. So that's important. Again, I don't want to say that universally physicians who work for a large health system may have employee incentives or make decisions that are in the best interest of the patient. That's not the message at all. But it's important that our physicians really can and do come at it with a very independent mindset, so they don't have any concerns about, do I have to refer within my hospital system, or is there a plus or minus to me financially in any way based upon the outcome of my diagnosis or treatment opinion. Does that help? Well, I'll assume it helps.
Absolutely. Thank you, Dan. The next question is, how much do you think demographics affect the trend of virtual care becoming more of a central strategy? Is there research that backs this up vis-a-vis different generations?
Sure. That may be for me as well, so happy to jump in there. What we've seen at Teladoc Health certainly is that if you look at the demographics of utilization and sort of break it down by age cohorts, you do see that the younger 25 to 40 age range tends to disproportionately use, meaning compared to their percentage of the population, but and a little bit less for older age groups. What I would say, though, is that it really is just a skew in the data. So maybe there are 15% more likely to use. But the broader message is that virtual care is being adopted and used pretty broadly throughout the different age groupings within a commercial population, for instance. I haven't seen published research on that, and it'll be really interesting to see as we go forward in the evolution of the industry, whether as certain groups age, right, they'll keep using, right. So the demographics will probably shift over time as those who are 50 become 60, et cetera, and it just becomes more commonplace.
Great, thank you very much. This question is also for you, Dan. I'm curious about surround sound marketing to drive member engagement. How do you get on their radar in the first place? Is it all employer directed? And how do you drive repeat use?
Yeah, good questions. And so by far our most successful clients are those with whom we partner pretty strongly, because it can't just be Teladoc marketing. And it's most impactful when all the tools and sort of messages that I highlighted on the slides are really supported by the employer taking a strong role, particularly from sort of the executive suite on down, in supporting virtual care within the employee population as something that's important. Right, so it's not buried in a benefit book somewhere. It really is highlighted through, whether it's signs in the workplace, whether it is, emails, or in other sorts of communications strategies that are very employer specific, because every population is a little different. Whether you've got a retail population, we've had large retailers that do things in the break room, right, and actually do a quick presentation about virtual care as part of open enrollment, within each store, for instance. Obviously very different in a professional services environment where people are all in an office or what have you. But regardless, really tailoring that communication strategy to the demographics and sort of the work environment of the population, and then really partnering with us on tailoring that communication so it really resonates with each employer's population. And then we do see repeat usage build. So getting the first trial or use is clearly the biggest hurdle. And then we definitely see that some on the upwards of 30 or 40% of people will reuse within a year or two, just based on obviously a need, but then also having a positive experience with virtual care the first time.
Great. Thanks so much. Steve, how do you go about becoming self-funded?
Oh, that's probably coming from an employer. So I would assume they have a consultant. They should be working with their consultant to evaluate their own claims and their premium spend, as well as their cash flow, to see if self-funding is the right option for them. It's not the right option for everybody. So I would definitely encourage them to work with their consultant for that.
Thank you. Next question is, are there additional member or employer costs after the initial virtual visit, for example, consultations with specialists? Dan?
Sure. So I'll answer it two ways. So in our telehealth service, each time you talk to a doctor for whether it's an urgent care type situation or maybe it's a dermatology visit or a behavioral health visit, those are each one is an individual visit that's paid for one way or another, some combination of the patient or the member paying or the plan paying. In our expert medical service and expert medical opinion, which is where I spent more of the time talking about today, that's all part of a PEPM. So there's no charge for each visit or each contact. It's a sort of a fully loaded, let's call it, PEPM or per employee per month that covers all the different interactions and cases and all the different use cases that I described during my presentation.
Okay. Can you tell me again how much repeated marketing should we at least try to do to encourage members to understand their plans and change of plans before open enrollment?
Sure. So the stats that I had cited illustrated that in virtual care we see doing, I said 12 to 15 touches can drive optimal results, and that clearly doesn't mean sending 12 to 15 direct mail pieces, just as an extreme example. It really is the combination of different touch points. So it could just be a poster in the lunchroom, and it could be email, and it could be many other things sort of put together. And we do a lot of that already. So certainly the message isn't, it's all sort of put on the employer, quite the opposite. We do a fair amount of, I'll call it sort of background marketing, what may appear to be background marketing. So through digital and as well as email. So social is what I mean by digital, as well as other digital means. And so we're doing a lot of that, but the message is it's definitely not just one or two touch points.
Does your solution assume employers have their claims data and know how to interrogate it or interpret it?
Yeah, I'll take that one. That's a big difference between the fully insured world and the self-funded world, especially in an independent kind of TPA world. In the independent TPA world, we don't view the data as being our data. It's the employer's data. So it's really up to us to make sure they have access to it, that we provide analytics and support for decision making. So I would say we're not assuming that they have to do all the work themselves in this world, but certainly it is important that they're working with someone who views the data as being the employer's data, not theirs.
Dan, anything to add to that?
No, I think you got it.
Okay. Next question is, how can we create easier access for mental health, whether through centers of excellence or virtual care? Dan?
Yeah, it's a very important and timely question. Where I'd always start is certainly I'd recommend offering mental health virtual care services. We offer it, other players offer it as well. And it really enables not just a more convenient experience for your employees, but will actually activate to get help many employees that wouldn't do it otherwise, because it avoids a lot of the stigma that is still present, unfortunately, in accessing mental health care services. And then, it is, and we actually did a different webinar, Teladoc, that I think last year on a survey we had done around stigma in the workplace. And one of the important findings was it is important for employers to broach the conversation, not with individuals per se, but with your employee base, about how it is okay to have the need for mental health services, and it's not going to cause a risk to your job or your sort of status within the company, because there's a lot of fear around that, honestly, and people are concerned about accessing services because they feel like it might in some way impact their career. And so I think it's important to have an open, maybe it's an open one-way conversation, but an open conversation about that to help make your employee base more comfortable accessing those types of services.
When a different procedure such as a microdiscectomy is recommended, is a physician recommended as well?
Yeah, I can
Dan,
take
I can take that first.
Oh,
let me take it first, and then I'll hand it over to you, because I know that we talked through all those options. So one of the things that we talked through all those different options of how George, in our example, could find a surgeon, a facility to do that surgery. So it really depends on how, what's set up by the employer of how that would work. I know specifically with Teladoc, they do have a service around finding a doctor. It's important that would be coordinated with, if we use that piece of the service, that it's coordinated with whatever the employer has put in place for physicians that are under contract and facilities that are under contract. So, Dan, if you want to talk about your find a doctor feature, that I know that you have that as well.
Yeah, absolutely. And I think I'd support or agree with exactly what you said. Part of our implementation is what we call clinical integration. So it's really trying to understand the other programs that an employer may have in place and trying to leverage those as we can from a referral perspective. Just to emphasize, sometimes when we provide an expert medical review, and even if the recommendation is a different treatment path, for instance, it could be that in many cases the patient stays with their own existing provider, community provider. And the community provider really loves the fact that they're getting the benefit of world-renowned expertise on the case. And so it isn't, I don't want to leave the impression patients are always switching doctors when they use our service. That's certainly not true. But sometimes they need to find a different specialist because based on the diagnosis and treatment, they need a different specialty than who they started with. And so in those cases, we would, as an example, we could use our Find a Doctor service to find one of those high-quality and network providers. And again, if it's with a type of specialty that you have or an employer has a specific program around, then we can refer into that as well.
Okay. This question I'd like both of you to address. How do you anticipate the current coronavirus crisis changing reimbursement levels for telemedicine by payers? Steve, do you want to start?
I could start, but I don't want to put Dan on the spot too much here because the IRS just made a ruling yesterday, so I don't know if they're ready with a with a position around this. I know that the new IRS ruling has said that testing around coronavirus is now considered preventive care, so it's not subject to the deductible and the high deductible health plan. So the testing, the actual testing that you hear about, where that's now covered at first dollar. But in terms of the telemedicine piece, Dan, are you ready to make a statement about what that means for you?
Well, thanks, Steve. I'll start by just making a broader recognition that, first of all, anything forward-looking about coronavirus, I think we're all guessing a little bit because it's changing every hour. But what we have seen in just the last week or two is more plans who have come out and said, whether it's for Medicare Advantage or commercial and different sort of flavors of it, a general theme clearly of opening up access to virtual care and telemedicine in this time of need, both from an availability perspective, but also waiving cost sharing, waiving copays, as Steve was referring to. How that's going to play out a few months from now, I can't guess, but certainly, the trend and the bias is towards expanding reimbursement, and I think that the experience that we'll see is this is almost a sort of there's a spotlight on telehealth and the value it can provide, and so that may or may not continue in the future afterwards because of this situation. Steve alluded to a particular sort of wonky question around can telemedicine be delivered under an HSA, HDHP plan and without cost sharing. There was an IRS rule sort of announcement yesterday that wasn't sort of 100% clear on that piece of it. So I'd always say talk to your benefits consultant or tax advisor on that. Clearly the message, though, and sort of the trend there, the bias was for, again, opening up as much as possible access to virtual care, making it as easy as possible for patients to utilize it because it keeps people from going to the doctor's office, obviously ERs unnecessarily, and causing potential further spread of the virus. So hopefully that helps.
Yes, indeed, and it is going to have to be our last word on our topic today because we have run out of time. Thank you for your questions. If we didn't get to your question, Maestro Health will follow up with you offline. I'd like to thank everyone for joining us today for the webcast. We hope you found it valuable. I'd especially like to thank Dan and Steve for taking the time and sharing their insights and experience with us. And a special thank you to Maestro Health for sponsoring this event. If you missed any part of the presentation, you'll be able to listen to a recorded version within 48 hours on the EBN and EBA websites, and we'll be sending you an email with a link to the recording. Thanks again for being with us, and have a great rest of your day.